Good afternoon. Can you hear? Good afternoon. Hello. Good afternoon.
Hello, ma'am.
Hello, can you hear?
Yes, ma'am.
Okay, very good. So let's start our lesson. I will write to leader of our group to send information about who is present in our lecture, okay? One moment. Can you hear?
Yes, ma'am.
Okay, I'm waiting for all students came. 27, 28 present. Okay, almost all.
Audio disconnect.
So, topic of today practical lecture is examination of patient with pathology of blood formation, hematopoietic system, and with pathology of connective tissue. First of all, we will we will study examination of patient with pathology of blood formation, hematopoietic system. So, hematopoietic system is a system in the body involved in the creation of the cell of blood. In developing embryos, blood formation occurs in aggregates of blood cells in the yolk sac called blood islands. As development progresses, blood formation occurs in the spleen, liver, and lymph nodes. When bone marrow develops, it eventually assumes the task of forming most of the blood cells for the entire organism. However, maturation, activation, and some proliferation of lymphoid cells occur in the spleen, thymus, and lymph nodes. All hematopoietic organs are divided into two categories depending on their relationship with the cells of the immune system. Central hematopoietic organs, which include the thymus, gland, and bone marrow. This group of hematopoietic organs is called primary because they have differentiation of lymphocytes. And peripheral hematopoietic organs, which include the spleen and lymphoid tissue. Spleen, lymphoid nodes, lymphoid tissue. This group is called secondary. Hematopoiesis is the formation of blood cellular components. All cellular blood components are derived from hematopoietic stem cells. One moment.
Mature blood cells have a limited
Can you see video?
Yes, ma'am.
Okay.
lifespan and must be continuously replaced through a process called hematopoiesis, which starts in the red bone marrow. All formed elements of the blood derive from a common progenitor, the hematopoietic stem cells, HSCs. HSCs are multipotent, meaning they can differentiate to all types of blood cells. They also have the ability to multiply constantly to maintain their numbers in the bone marrow. Formation of blood cells from hematopoietic stem cells is a multi-step process involving several intermediate progenitors and is regulated by a network of signaling molecules known as cytokines. These cytokines control the proliferation, differentiation, and survival or death of the various progenitors. By doing so, they maintain steady-state levels of blood cells in normal situations, and, in response to certain stimuli, induce production of a particular cell type. For example, in response to blood loss, production of red blood cells is accelerated. Differentiation starts when progenitor cells develop surface receptors for a specific stimulating factor. Once this has happened, the cells lose their potency and become committed to a certain cell type. Production of red blood cells, RBC, or erythrocytes, is stimulated by erythropoietin, EPL. During the differentiation process, the cells reduce in size, increase in number, start making hemoglobin, and lose their nucleus. EPO is produced predominantly by the liver during fetal development and by the kidneys in adulthood. Low levels of EPO are constantly secreted and are sufficient to compensate for normal red blood cell turnover. When RBC count drops, such as during blood loss, the resulting oxygen deficiency state, hypoxemia, is detected by the kidneys. The kidneys respond by increasing their EPO secretion, which leads to increased red blood cell production by the end of 3 to 5 days. People living at high altitudes usually have higher RBC count as a response to lower oxygen levels. Athletes whose demand for oxygen is more elevated also have higher RBC counts. Production of granulocytes and macrophages, the key players of the body's innate immune response, is controlled by several colony-stimulating factors, CSFs. Normally, these cells are kept at a more or less constant number by relatively low levels of CSFs, but their production can increase greatly and quickly upon infection. CSFs are commonly secreted by mature lymphocytes and macrophages, but can be produced, if needed, by virtually any organ or cell type. CSF production may increase 1,000-fold in response to indicators of infection, such as bacterial endotoxins. Production of platelets is stimulated by thrombopoietin, TPO, a hormone secreted by the kidneys and liver. TPO is responsible for formation of megakaryocytes, the gigantic cells that develop as a result of multiple rounds of DNA replication without cell division. A megakaryocyte gives rise to tens of thousands of platelets, which are essentially broken fragments of its cytoplasm. Production of platelets is subject to a classic negative feedback loop. Reduced platelet levels in the blood promote their production, while elevated levels inhibit it.
Okay, let's talk about general complaints of the patient with diseases of blood system. So first of all, it is the most common is weakness, dizziness, tinnitus, and fatigue. Specific complaints of the patient with blood diseases. Decreased appetite, aversion to certain foods, meat, fish, bread, burning sensation and pain in the tongue after eating, dull pain in the epigastric region, a feeling of fullness and belching, stool multiply, semi-liquid or constipated. Specific complaints is fever. Fever can be provoked by, can be caused by acute leukemia, lymphogranulomatosis, iron deficiency anemia, Addison-Berman disease, agranulomatosis, and hemophilia. The most common specific complaints of iron deficiency anemia are taste disturbances, fragility of hair loss, and premature graying, dysphagia, brittle nails, iron deficiency anemia caused. Specific complaints of hemolytic anemia are general weakness, dizziness, fatigue, shortness of breath, decreased working capacity, fever, bleeding from the nose, mucous membranes, digestive tract, menorrhagia. Specific complaints are the following also. Pain in the extremities, especially in lower extremities, usually can caused by anemia. Gait disturbances, lower extremity pain along the nerves, sensitivity disorders in the form of paresthesia, numbness, tingling, lack of sensitivity in the distal extremities, B12 deficiency. Heaviness in the head with excruciating pain, pain in the heart, pain in the bones and joints, red cyanotic color of the skin and visible mucous membranes. In patient with erythemia, Vaqu's disease and erythrocytosis. Specific complaints are also bone pain and back pain. In tumors, multiply myeloma, lymphoma, and tumor metastasis, and muscle weakness. Plumper-Vinson syndrome, difficulty swallowing dry or solid food, iron deficiency anemia, a feeling of itching and the presence of foreign body in the pharynx. This is the result of atrophic changes in the mucous membrane of pharynx and esophagus. Decreased appetite, the need for spicy, sour, and salty foods. Pain in the right or left hypochondrium and sign of hepato and or splenomegaly. Colleagues, here you can see objective examination of the patient, the main features of objective signs, features of skin changes, mucous membrane changes, lower extremities, toes, fingers, changes of objective examination in patient with diseases of blood system. Let's talk about skin color. Skin color may be different. It may be pale color in patient with anemia, pale with yellow tint in hemolytic anemia, lemon yellow in B12 folate deficiency anemia, redness of the skin, erythrocyte with rash, T-cell lymphoma, or chronic lymphocytic leukemia. Bronze color of the skin or gray color of the skin, you can see here. In patient with hemochromatosis, you can see cyanotic or cherry red color of the skin. In patient with intoxication, poisoning of carbon monoxide, you can see petechia in patient with thrombocytopenia and vasculitis and dysproteinemia. Here you can see changes in the mouth. Angular stomatitis, telangiectasia. You can see color of the tongue, smoothness, buccal mucus, petechia, and glossitis and angular stomatitis in iron deficiency anemia. Here you can see gum hypertrophy in acute myeloid leukemia. Here you can see hereditary hemorrhagic telangiectasia and koilonychia in iron deficiency anemia. Colleagues, objective examination, you can see changes of joints. You can see deformity, swelling, and restricted movement, and swollen joints in hemophilia. Here you can see. You can see purpura petechia in patient with thrombocytopenia. Changes of feet characterized by affection of toes, gangrene you can see. Changes of peripheral circulation. Also changes of fundi characterized by fundal hemorrhages in thrombocytopenia. Palpation of bones is very important method of physical examination. Palpation of flat bones or epiphyses or tubular bones and also tapping over them is painful in the presence of marked hyperplasia of the bone marrow in acute leukosis. Examination of oral cavity is very important also. Pronounced atrophy of the tongue papilla is characteristic of vitamin B12 deficiency anemia. The tongue surface becomes smooth as if varnished hunter glossitis. Intense caries of the teeth and inflammation of the mucus around dental necks. Alveolar pyuria often occurs in patients with iron deficiency anemia. Necrotic ulcerous tonsillitis and stomatitis are frequent symptoms of acute leukosis. Colleagues, here you can see picture of palpation, examination of lymphatic nodes, palpation lymphatic nodes. Here you can see enlargement of visually enlargement of lymphatic nodes. Here you can see schematic lymphatic nodes which are present in the head and neck, submental, submandibular, tonsillar, parotid, preauricular, postauricular, superficial cervical, deep cervical, posterior cervical, occipital, supraclavicular. So, considerable enlargement of the regional lymphoid nodes is discovered by local swelling of the neck above the clavicules in the armpits and groin. Less frequently, swelling of other location can be revealed by inspection of patient with certain forms of leukosis. Soft, flat submandibular nodes less than 1 centimeter are often palpable in healthy children and young adults and healthy adults may have palpable inguinal nodes up to 2 centimeters, which are considered normal. Lymphoid nodes may be enlarged not only in diseases of the blood system, but also in some other diseases, such as infection diseases, tuberculosis, cancer, metastasis, systemic inflammatory diseases of connective tissue, and local inflammatory process. Lymphoid nodes of only one group are first affected, but later other groups become involved too. Enlarged lymph nodes in leukosis and malignant lymphomas are painless. They never fuse with the skin, do not suppurate or form fistula, as distinct from affections of other etiology. Nodes are pasty and elastic in lymphoid leukosis. Lymphoid nodes are firm and fuse into conglomerates, sometimes large in diameter in lymphogranulomatosis, and especially in lymphosarcoma. Examination of spleen is very important part of examination of blood system. Normal spleen is impalpable. It can only be palpated in rarer cases of extreme ptosis and more frequently in enlargement of the organ. The spleen is enlarged in many diseases of the hematopoietic system, but also some acute and chronic infection diseases, liver cirrhosis, thrombosis or compression of the splenic vein. Considerably enlargement of the spleen is called splenomegaly. As the greatest enlargement of the spleen is observed at terminal stage of chronic myeloid leukosis. Not only the spleen, but also liver sometimes becomes enlarged, hepatosplenomegaly, in leukosis and hemolytic anemia. Examination of bone marrow. A bone marrow biopsy is a procedure that involves removing a sample of bone marrow and testing it for sign of disease. During the procedure, your healthcare provider removes a small sample of marrow from inside a bone. Afterwards, a specialist called pathologist examines the cell from the marrow under a microscope, looking for signs of disease. You can see equipment for bone marrow examination. Let's talk about blood. So, components of blood. Plasma, straw-colored liquid that contain dissolved substances, including clotting factors. Serum, plasma minus the clotting factors. Blood consists of 55% plasma and 45% formed elements. Formed elements are the following: red blood cells, white blood cells, and platelets. One moment. Can you see video? Students? Hello?
Yes, ma'am.
Okay.
plasma is not only water, it also contains other substances. We have 13 compounds which help us in forming clots. Now, in this video, we will mainly focus on the buffing coat layer. We won't focus that much on the plasma and the blood cells. But I do have a specific video on the red blood cells. Watch that up front. So anyway, let's focus on the buffing coat layer. The middle layer that makes up 1% of the volume. The buffing coat layer contains two main things: platelets and leukocytes, or white blood cells, which go as white. Now, platelets are essentially small things that help in formation. So, where do these platelets come from? So, how are they made? Well, platelets originally come from cells. So, what happens is that you have this cell in the bone marrow that have granules and will come or differentiate cell known as a carrier cell. These cells contain active. With the megakaryote, when the cell ruptures through some process, it will actually release parts from its cells with fragments and those parts. And these are what we know as platelets. The platelets are come from the megakaryote cells when they rupture. And what platelets do is that, as I mentioned, they help form clots together with the help of clotting factors that are found in plasma. Now, the other component of the buffing coat layer are leukocytes, or white blood cells. Now, there are so many types of white blood cells, and what they do is that they help our body fight infections and other stuff. So they're essentially the body. White blood cells can be divided broadly into parts. White blood cells that do not contain granules, called agranulocytes, or granulocytes. White blood cells that contain pathogen granules. Now we'll firstly focus on the granulocytes, the white blood cells that contain granules. We have three main granulocytes. These are the neutrophils, eosinophils, and basophils. Let's look at each one of them in sequence. The neutrophils' main function is phagocytosis of foreign agents, such as pathogens. In the process, they will blow up, and so they're quite dangerous and highly inflammatory. The eosinophils are basically cells that are part of the immune response. These are chemicals that will activate another cell called mast cells, and this will essentially promote the immune response. The eosinophils also have a role in hosting parasites and fungi, and the eosinophils are seen they're a big factor in the pathogenesis of asthma. Then you have the basophils. Now, the basophils also secrete chemicals of response. In mice, it's been found that basophils are also antipathetic cells, which are cells that can activate. Okay, so those are the three granulocytes. Now let's look at the agranulocytes, cells that do not contain granules. We have mast cells, dendritic cells, monocytes. Dendritic cells are extremely cells that contain first line of defense. They are phagocytes and are the main antigen cells. And antigen cells means that cells are cells that activate cells. Mast cells, they look like they contain, and they do, but they are not classified as granulocytes. Mast cells really exist, and they're very big in the allergic response as well as they release histamine when the allergy or the person release of histamine will cause vasodilation. Now we have monocytes. Monocytes, they circulate actually in blood, and they're phagocytes, so they eat up things. But when a monocyte migrates from the blood into the monocyte becomes what's known as macrophage. Macrophages have the function of phagocytes, and they're also anti-dendritic cells, so they activate T lymphocytes, just like a dendritic cell. So what are the T lymphocytes? Where T lymphocytes, or known as T cells, can be divided into two main types of cells. These are the CD4 T cell and CD4 T cells are known as helper cells, and they essentially promote the macrophage activity, as well as they will activate T cells. Now the CD8 T cells are known as the cytotoxic T cells, and their main function is to kill infected cells, tumor cells, or abnormal cells. Now, just to confuse further, both the anti-lymphocytes or memory cells for a specific antigen. And so there's actually we have T helper cells, cytotoxic T cells, and T lymphocytes. Then you have the B lymphocytes. The B lymphocytes, or known as T cells, they can be divided into plasma cells, or they can be memory once they're activated. Plasma cells essentially antibodies that help combat allergens or pathogens. Then you have the memory B cells that are cells that form a specific memory to antigen. I hope that was not too confusing, that last bit. If that was, you can watch a video on just
So 91.5% water and 8.5% solutes, 8.5% solutes, 7% proteins, plus 1.5% other solutes. Plasma proteins are clotting factors, fibrinogen, globulins, including antibodies, and albumins, and specialized carrier proteins, lipoproteins. Other solutes include glucose, fatty acids, enzymes, hormones, gases, ions, wastes, urea, uric acid, ammonium, salt, creatinine, and bilirubin. Plasma proteins. 3 types of plasma proteins are the following: albumins, globulins, and fibrinogen. Albumin accounts for 60–80% plasma protein made by the liver. Creates colloid osmotic pressure that draws water from intestinal fluid into capillaries to maintain blood volume and pressure. Globulins carry lipids. Alpha globulins, beta globulins, and gamma globulins. Gamma globulins, antibodies that function in immunity. Gamma globulins are antibodies. Beta globulins transport lipids and fat-soluble vitamins. And alpha globulin transport lipids and fat-soluble vitamins also. Fibrinogen constitutes 4% of plasma proteins, important clotting factor, converted into fibrin during the clotting process. Let's talk about red blood cells. A function. Red blood cells, erythrocytes, are the most abundant cells in the bloodstream and contain hemoglobin, the compound that carries oxygen through the body. Apart from carrying oxygen, they also release the enzyme carbonic anhydrase, which allows water in the blood to carry carbon dioxide to the lungs, where it is expelled, and controls the pH of the blood by acting as acid-base buffer. Biconcave shape increases the surface area so more oxygen can be carried. Contain hemoglobin, the oxygen-carrying molecule, 250 million molecular cell. No nucleus, extra space inside. And biconcave shape. Abnormalities of red blood cells. Anisocytosis, excessive variation in the size of erythrocytes. The change in the shape of erythrocytes is called poikilocytosis. In addition to round erythrocytes, blood contain also erythrocytes of oval, pear-shaped, and other configurations. Microcytosis. Prevalence of smaller erythrocytes occurs in iron deficiency anemia. Megalocytes appear in the blood of patients with vitamin B12 deficiency anemia. Hemoglobin is a protein specially adapted for oxygen transport. Hemoglobin consists of two components, globin and hem. Globin is a protein that is made up of two alpha and two beta chains. Hem, an iron-containing ring-like non-protein pigment that binds to each of the four globin chains. Hematocrit, also known by several other names, is the volume percentage of red blood cells in blood measured as part of the blood test. The measurement depends on the number and size of red blood cells. Color index. The average content of hemoglobin in one erythrocyte is called color parameter of blood. Reticulocytes are immature red blood cells. In the process of erythropoiesis, red blood cell formation, reticulocytes develop and mature in the bone marrow and then circulate for about a day in the bloodstream before developing in the mature red blood cells. Erythrocyte sedimentation rate is the rate at which red blood cells in anticoagulated full blood descend in a standardized tube over a period of 1 hour. It is a common hematology test and is a non-specific measure of inflammation. White blood cells. Their main function is to defend the body against foreign microorganisms and substances. Leukocyte formula. Lymphocytes 20–45%, monocytes from 3 till 10%. Neutrophils segmented count is from 40 to 70%. Basophils normal from 0 till 1%. Involved in immediate type allergic reactions. Eosinophils from 1 till 5% normal are involved in fighting parasitic infestations and allergies. Next component of blood named lymphocytes. Lymphocytes and plasma cells are components of the immune system which also arise from hematopoietic system cells. Lymphocytes broadly include natural killer cells, a component of the innate immune system, and T cells and beta cells, which are involved in adaptive immunity. Primary lymphoid organs, while lymphopoiesis occurs, include the bone marrow and thymus, while secondary lymphoid organs such as lymphoid nodes, spleen, mucus, and cutaneous associated involved predominantly in immune sensitization and selection. Next, about platelets. Platelets, blood cells that formed from bone marrow cells. Main function, blood clotting. Let's talk about biomarkers of the blood associated with COVID-19. Hematology, decreased lymphocytes, platelets, neutrophils. Coagulation, DDMR, increased. And increased markers of inflammation. C-reactive protein, erythrocyte sedimentation rate, procalcitonin, and ferritin. Blood disorders affecting red blood cells are the following: anemia, polycythemia vera, sickle cell disease, thalassemia. Anemia is divided due to color index into hypochromic anemia, normochromic anemia, and hyperchromic anemia. Blood disorders affecting white blood cells, divided into lymphoma, leukemia, and myelodysplastic syndrome. Blood disorders affecting platelets, thrombocytopenia, divided into idiopathic thrombocytopenic purpura and heparin-induced thrombocytopenia, and essential thrombocytosis. Examination of coagulogram. Very important is to examine the international normalized ratio, INR. It's a laboratory measurement of how long it takes blood to form a clot. It is used to determine the effects of oral anticoagulants on the clotting system. In healthy people, INR of 1.1 or below is considered normal. It is very important to check prothrombin time. Reflects plasma clotting time expressed in seconds. Prothrombin time rate reflects conversion of the enzyme to the active form prothrombin. Its increase compared with the normal suggests lack of vitamin K, clotting factors, possible liver disease. Let's talk about examination of patient with pathology of connective tissue. Connective tissue is divided into loose connective tissue, dense connective tissue, and specialized connective tissue. Loose connective tissue holds organs in place and attaches epithelial tissue to other underlying tissue. Dense connective tissue helps attach muscles to bone and link bones together at joints. Specialized connective tissue encompasses a number of different tissue with specialized cells and unique ground substances. Some are solid and strong, while others are fluid and flexible. Examples include adipose, cartilage, bone, blood, and lymph. Can you see video?
Yes, ma'am.
Okay.
The musculoskeletal system provides mechanical support for the body, protects internal organs, and permits movement. It is composed of bones, cartilage, skeletal muscles, joints, and connective tissues such as tendons and ligaments. Bones also serve as the body's main mineral reservoir. They store calcium and phosphate and release them according to the body's needs. Red bone marrow is the body's production center for blood cells. The central nervous system controls body movements by stimulating skeletal muscles to contract. Contraction of skeletal muscles moves bones, which act as levers. Bones articulate with each other through joints. Cartilage provides padding for the ends of bones within joints. Muscles are connected to bones by tendons, while bones are held together by ligaments. Bones are classified according to their shapes and corresponding functions. Long bones are responsible for most body movements. Short bones provide some limited motion, while flat bones and irregular bones are mainly protective and supportive. The bone tissue, or osseous tissue, is composed of bone cells and a characteristic extracellular matrix. Bone matrix is made of an organic component, mainly collagen, and an inorganic component of minerals, mainly calcium. Collagen gives bones flexibility, while calcium provides stiffness. Without calcium, bones would be soft and bend easily. On the other hand, without collagen, bones would be brittle, like chalk. Bones renew and remodel throughout a person's life in a process known as bone remodeling, which constantly removes old bone tissue and adds new bone tissue. Bone remodeling serves to reshape bones to adjust to changing mechanical needs and to repair everyday micro-damages as well as fractures following injuries. This process also underlies the mechanism by which the constant levels of plasma calcium and phosphate are maintained. Bone remodeling is performed by two types of cells: osteoclasts, which dissolve bone matrix, and osteoblasts, which deposit new matrix around themselves to form new bone tissue. Bone remodeling is under control of complex signaling pathways. Major regulators include parathyroid hormone, vitamin D, growth hormones, glucocorticoids, thyroid hormones, estrogen, and testosterone. The most common bone disease is osteoporosis, or porous bone, in which bones lose mass and weaken, increasing risks of fractures. Osteoporosis is commonly due to old age and some other unavoidable factors, but can also develop from or worsen by hormone imbalances, deficiencies in calcium, vitamin D, or proteins, and sedentary lifestyles. Most common and also most movable type of joint is synovial joint. The bones of a synovial joint are separated by a cavity containing synovial fluid, which serves as lubricant. Together, the fluid and the cartilage that lines the bone surfaces make the movements at synovial joints almost friction-free. There are also small fibrous sacs containing synovial fluid, called bursae, located between muscles, or between a tendon and a bone. Bursae cushion muscle movements and help tendons slide smoothly over the joints. The most common disease of joints is arthritis. There are two main types of arthritis: osteoarthritis, also called degenerative joint disease, is the wear and tear condition of the joint, commonly due to old age. Osteoarthritis is characterized by loss of cartilage, bone spurring, and no major inflammation. Rheumatoid arthritis is a result of joint inflammation, with immune cells and inflammatory chemicals causing damage to the joint. It's not clear how rheumatoid arthritis starts, but genetic predisposition together with infection of the joint are likely to be among the causes. Muscular tissue consists of specialized elongated muscle cells, called muscle fibers, which are bundled into fascicles. Muscle fibers, fascicles, and whole muscles are wrapped in layers of connective tissue, which provides support and protection. These connective tissue coverings are continuous with the tendon that connects to a nearby bone. Fascicle arrangement determines the strength of a muscle and the direction it pulls. Most common muscle disorders are caused by injury or overuse and include sprains, strains, cramps, and tendinitis.
Musculoskeletal conditions affect joints such as osteoarthritis, rheumatoid arthritis. One moment.
Skeletal muscles are composed of muscle fibers, which in turn are repetitive functional units called sarcomeres. Each sarcomere contains many parallel overlapping.
Excuse me. So, musculoskeletal conditions comprise more than 150 diagnoses that affect the locomotor system, that is, muscles, bones, joints, and associated tissues such as tendons and ligaments, as listed in the International Classification of Diseases. They range from those that arise suddenly and are short-lived, such as fractures, sprains, and strains, to lifelong condition associated with ongoing pain and disability. Musculoskeletal conditions affect joints, such as osteoarthritis, rheumatoid arthritis, psoriatic arthritis, gout, ankylosing spondylitis. Affection of bones, such as osteoporosis, osteopenia, associated fragility fractures, traumatic fractures. Affection of muscles, such as sarcopenia. Affection of the spine, such as back and neck pain. Affection of multiple body areas or systems, such as regional and widespread pain disorders, and inflammatory diseases such as connective tissue diseases and vasculitis then have musculoskeletal manifestation, for example, systemic lupus erythematosus. Common symptoms of musculoskeletal disorders include pain, weakness, stiffness, joint noises, and decreased range of motion. Inflammation may cause pain, swelling, warmth, tenderness, impaired function, and sometimes redness of the overlying skin. When inflammation affects the joint, fluid may accumulate inside the joint, causing pain, swelling, and decreased range of motion. Common symptoms of musculoskeletal condition include localized or widespread pain that can worsen with movement, edging or stiffness of the entire body, the feeling that muscles have been pulled or overworked, fatigue, sleep disturbances, twitching muscle sensation or burning in the muscle. Musculoskeletal pain is different. It may be bone pain, it may be muscle pain, it may be tendon and ligament pain, it may be fibromyalgia, joint pain, and tunnel syndrome pain. Symptoms of musculoskeletal pain depend on whether the pain is caused by injury or overuse and whether it is chronic or acute. Symptoms can also differ from person to person. Common symptoms include localized or widespread pain that can worsen with movement, edging or stiffness of the entire body, the feeling that muscles have been pulled or overworked, fatigue, sleep disturbances, twitching muscles, sensation of burning in muscles. Primary methods examination, physical examination of musculoskeletal system. Used for physical examination of musculoskeletal system are inspection and palpation. Percussion and auscultation are only used in special situations, such as percussion pain or vertebrae auscultation for bone crepitus. The examination should include assessment of muscle strength and range of motion and maneuvers to test joint function and stability. Examination of musculoskeletal system also should include assessment of surrounding tissue, noting skin changes, subcutaneous nodules and muscle atrophy, Assessment of inflammation, especially redness, swelling, warmth, and tenderness. Use the back of your fingers to compare the involved joint with its unaffected contralateral joint, or with nearby tissue if both joints are involved. Colleagues, you can see picture how to do physical examination of musculoskeletal system. You should ask the patient to walk for a few steps, then come back. Look for pain or limp. You have to check arms. You have to inspect hands for swelling or deformity. Ask patient to make a first and open close fingers, test hand function. And squeeze metacarpals, test for inflammation. Press our supraspinatus, test for hyperalgesia. Patient turns palms up and down with elbows at side, test supination and pronation of wrist and elbow. Ask patient to put hands behind head, test shoulder movement. Patient flexes elbows to touch shoulder, test elbow flexion. Flex each hip with hand or knee. Rotate hips internally and externally. Palpate each knee for warmth and swelling and inspect ankles and feet. Squeeze forefoot. Test for metatarsophalangeal synovitis. You have to check spine. Patient looks at ceiling and then puts chin on the chest. Test flexion and extension cervical spine. Then ask patient to try to put ear on shoulders. And patient slides hand down, leg to knee. You should inspect spine from behind and side, looking for scoliosis, kyphosis, or located deformity. Ask patient to touch toe. Stand behind patient and hold their pelvis. Ask them to turn from side to side without moving their feet. Examination of musculoskeletal system include also laboratory tests and imaging tests. Laboratory tests are the following: erythrocyte sedimentation rate, C-reactive protein, calcium, phosphate, alkaline phosphatase, uric acid, rheumatoid factor, anti-nuclear antibodies, anti-DNA antibodies, vitamin D3, vitamin D25 dehydroxy, myoglobin. Imaging tests: X-ray, bone scanning, computer tomography, MRI, densitometry, and ultrasonography. Examination of musculoskeletal system, examination of blood. First of all, C-reactive protein, calcium level, and phosphate level. Alkaline phosphatase, uric acid, rheumatoid factor. Anti-nuclear antibodies and anti-DNA antibodies. Attack antigens in cell nuclei and are found in autoimmune disorders such as systemic lupus erythematosus. Next, lupus erythematosus cells, vitamin D25 dehydroxy and vitamin D1 25 dehydroxy. The most prevalent instrumental method is X-ray. X-ray are typically done first. They are most valuable for detecting abnormalities in bone and are taken to evaluate painful, deformed, or suspected abnormal areas of bone. Plain radiography show anatomical changes that are of value in the differential diagnosis of many bone and joint diseases. Radiographs are of diagnostic value in osteoarthritis, where they demonstrate joint space narrowing that tends to be focal rather than widespread inflammatory arthritis. Other features include osteophytes, subchondral sclerosis, bone cysts, and calcified loose bodies within the synovium Radiographs may show erosions and sclerosis of the sacroiliac joints. A direct arthrography. It is X-ray procedure in which a radiopaque dye is injected into a joint space to outline the structures, such as ligaments, inside the joints. Arthrography can be used to view torn ligaments and fragmented cartilage in the joint. However, magnetic resonance imaging is not generally used in preference to arthrography. Bone scanning is a typical is a type of radionuclide scanning imaging procedure that occasionally used to diagnose a fracture, particularly if other tests such as plain X-ray and CT or MRI do not reveal the fracture. This is useful in patients suspected of having metastatic bone disease and Paget disease. Computed tomography and MRI may be done to determine the extent and exact location of damage. This test can also be used to detect fractures that are not visible on X-ray. MRI is better than CT for imaging some bone abnormalities, such as small fractures of the hip and pelvis. CT is useful if MRI is not recommended or unavailable. Computed tomography can be used in the assessment of patients with bone and joint disease, but has largely been superseded by MRI, which gives better visualization of soft tissue structures. CT may be used when MRI is contraindicated. MRI gives detailed information on anatomy, allowing three-dimensional visualization of bone and soft tissue that cannot be adequately assessed by plain X-ray. Densitometry. The most accurate way to evaluate bone density, which is necessary when screening for diagnosing osteopenia or osteoporosis, is with dual energy X-ray absorptiometry. Is also used to predict personal risk of fracture and can be useful for monitoring the response to treatment as well. Play a key role in the diagnosis and management of osteoporosis. Next method, named ultrasonography, is being used more and more frequently to identify the inflammation around joints and tears or inflammation of tendons. Is more sensitive than clinical examination for the detection of early synovitis and is used increasingly in the diagnosis assessment of patients with suspected inflammatory arthritis. Other diagnostic procedures include joint aspiration, arthrocentesis. Is used to diagnose certain joint problems. For example, it is the most direct, accurate way to determine whether joint pain and swelling is caused by infection or crystal-related arthritis, such as gout. For this procedure, doctor first injects anesthetic to numb the area. Then the doctor inserts a larger needle into the joint space, draws out and examines the fluid under a microscope. Doctor removes as much fluid as possible and noted its color and clarity. Next is nerve and muscle test. Nerve conduction studies help determine whether the nerves supplying the muscle are functioning normally. Electromyography, usually done at the same time as nerve conduction studies, is a test in which electrical impulses in the muscles are recorded to help determine how well the impulses from the nerves are reaching the connection between nerves and muscles, and from there the muscles. Nerve conduction studies, together with electromyography, help indicate whether there is a problem primary in the muscles, nerve system, or neuromuscular junction, such as myasthenia gravis. Nerve conduction studies are particularly useful for the diagnosis of peripheral nerve disorders, such as carpal tunnel syndrome and ulnar nerve palsy. Connective tissue diseases. There are several types of connective tissue diseases. It's useful to think of two major categories. First category includes those that are inherited, usually due to single gen defect called as mutation. And second category includes those where the connective tissue is a target of antibodies directed against it. This condition causes redness, swelling, and pain. Connective tissue are made up of two proteins, collagen and elastin. When a patient has a connective tissue disease, the collagen and elastin are inflamed. Connective tissue disease is any disease that affects the parts of the body that connect the structures of the body together. Connective tissue diseases due to single gen defects cause a problem in the structure and strength of connective tissue. Examples of these conditions include Ehlers-Danlos syndrome, epidermolysis bullosa, Marfan syndrome, osteogenesis imperfecta, Alport syndrome, Lewis-Dietz syndrome, and autosomal dominant inheritance. Connective tissue diseases characterized by inflammation of tissue are caused by antibodies that the body incorrectly makes against its own tissue. These conditions are called autoimmune diseases. Polymyositis, dermatomyositis, rheumatoid arthritis, scleroderma, Sjogren's syndrome, systemic lupus erythematosus, vasculitis, Goodpasture syndrome, granulomatosis, mixed connective tissue disease. Because there are so many different kinds of connective tissue diseases, symptoms may vary and may affect different parts of the body. It can be include affection of bones, joints, skin, heart and blood vessels, lungs, head and face, and head. First of all, you have to check physical examination. You have to check, ask patient to walk for a few steps, then come back, and inspection hands and other function. Next, physical examination. You can see synovitis and the deformation of joints in rheumatoid arthritis. And you can see Heberden and Bouchard nodes in osteoarthritis. A very specific phase in patient with systemic lupus erythematosus. You can see butterfly rash here. Also can be rash, alopecia, mouth ulcers, and eyes, affection of eyes. You can see in rheumatoid arthritis, scleritis. You can see the formation of legs, swelling and restricted movements. You can see. You can see affection of feet, deformity, swelling, and redness, acute gout here. The formation of nails dystrophy in psoriatic arthritis, and rheumatoid nodules in rheumatoid arthritis. Rheumatoid arthritis blood tests. The most important blood tests in rheumatoid arthritis are the following: anticycline citrullineated peptide, antinuclear antibody, C-reactive protein, erythrocyte sedimentation rate, interpreting the result HLA tissue typing, and lymph serology. Rheumatoid factors and uric acid. A person who tests positive for rheumatoid factors could have rheumatoid arthritis. However, doctors cannot conclude this form, and rheumatoid factor test alone, as several other conditions, can increase the amount of rheumatoid factor in the body, including gout. Similarly, negative rheumatoid factor test is insufficient evidence to confirm that the person does not have rheumatoid arthritis. Presence of rheumatoid factor alongside anti-citrullineated peptide and symptoms typical rheumatoid arthritis, however, make it likely that a person has this condition. And uric acid. Presence of high level of uric acid indicates that a person is more likely to have gout than rheumatoid arthritis. You can see imaging tests for patient with rheumatoid arthritis. Here you can see fingers. There are three main types of rheumatoid arthritis imaging tests used to diagnose: X-ray, MRI, and ultrasound. Next disease named systemic lupus erythematosus. Tests used to diagnose SLA may include anti-nuclear antibody, anti-Smith antibody, CBC with differential chest X-ray, serum creatinine, and urinalysis. Other tests to learn more about condition are the following.
Actin.
One moment.
injury to a group of cells can subsequently lead to organ injury. The pathophysiology of SLE is thought to involve an interplay between genetics. For example, SLE is seen in monozygotic twins, and there's also influence of epigenetics, immunology factors, hormonal factors such as estrogen, and mainly environmental factors. Environmental factors is thought to be the initial trigger for SLE. These environmental factors include UV light, infections such as Epstein-Barr virus, smoking, and even potentially certain drugs that increase oxidative stress damage that will lead to the cells being damaged. Important to note that these environmental risk factors are agents which humans are commonly exposed to, suggesting that people who develop SLE have to have some sort of genetic susceptibility. When cells are damaged, they can try to repair themselves. If they can't, they undergo programmed cell death called apoptosis. When cells undergo apoptosis, internal proteins are displayed on their surface blebs. A normal response is when our immune system clears up these apoptotic cells. This is done by phagocytes such as macrophages and monocytes. However, if apoptotic cells are not cleared efficiently, nuclear material is exposed to the immune system, which may then become sensitized, and eventually the immune system will mount an attack on our own proteins and nuclear material. Some people who develop SLE are seen to have deficiency in some complement proteins such as C1, C2, and C3 and C4. These proteins are important to help macrophages clear up certain cells, such as these apoptotic cells we mentioned earlier, through opsonization, for example. Deficiency in these early complement proteins mean apoptotic cells are not cleared efficiently. When proteins and nuclear material are not cleared properly, they are exposed to the immune system. The immune system is thought to become sensitized to these materials, so next time they encounter such material, their body will mount an immune response towards their own proteins and nuclear material. The process of sensitization begins when an immature antigen-presenting cell, such as an immature macrophage or dendritic cell, notices and picks up proteins and nuclear material from the apoptotic cells through special receptors such as toll-like receptor. The antigen picked up by the antigen-presenting cells include nuclear proteins, cytoplasmic proteins, and membrane components of the cell. Nuclear antigens include histone core, double-stranded DNA, and ribonuclear protein complexes include SM, NRNP, and Rho. Cytoplasmic components also include Rho, a small variant, and cell membrane antigen, including cardiolipid, found in mitochondria, and may be platelet membranes or red blood cell membrane components as well. Regardless, antigens that are picked up by the antigen-presenting cell are then displayed on the surface of the antigen-presenting cell. Antigens are presented to naive T helper cells in nearby lymph nodes. The naive T helper, when activated, can become a number of different types of T helper cells. In the case of systemic lupus erythematosus, where antibodies play the main role, interleukin-4 secreted favors T helper 2 cell maturation. T helper 2 cells promote the humoral immune response, and so the antibody-mediated immune response. T helper
Next disease of systemic next systemic disease named scleroderma. A general and routine test that might be ordered to help monitor patient health status may include complete blood count to evaluate red and white blood cells, a comprehensive metabolic panel to evaluate organ function and chemical electrolyte balance, urinalysis, and thyroid function test. Sometimes a biopsy may be performed to evaluate fibrosis in affected tissue. Very important to check antinuclear antibodies. This test is positive with a variety of connective tissue and autoimmune disorders, present in about 95% of those with scleroderma, typically with a sclerotic centromere or more rarely nuclear pattern test result. C70 antibody, scleroderma antibody positive in up to 60% of adults with systemic sclerosis, and centromere antibody present in 96% of people with limited cutaneous scleroderma and strongly associated with CREST syndrome. A non-laboratory test in patients with scleroderma include lung function test. When it is suspected that lungs have been affected, X-ray may be done to detect calcium deposit and evaluate the health of the lungs. Computer tomography scan may be performed to look for lung damage. Cardiac testing and monitor electrocardiogram and echocardiogram, gastrointestinal test, endoscopy, manometry, and inspection of kidney function, ultrasound. Next systemic disease named vasculitis. Laboratory test, blood and urine test may show abnormal level of certain blood cells and antibodies protein in the blood. These tests look for signs of inflammation such as high level of C-reactive protein. Colleagues, you can see picture, photo of patient leg. You can see skin changes with vasculitis. Complete blood cell count can tell whether you have enough red blood cells. Blood tests that look for certain antibodies, such as the anti-neutrophil cytoplasmic antibodies test, can help diagnose vasculitis. Biopsy, this is often the best way to make a firm diagnosis of vasculitis. During a biopsy, the doctor takes a small sample of affected blood vessel or organ to study under a microscope, looking for signs of inflammation or tissue damage. And good posture syndrome. Diagnosis involves rolling out disease that cause similar symptoms, including other forms of vasculitis. Depending on organs affected, the following diagnostic test may be ordered. Urinalysis, excessive protein or presence of red blood cells may indicate kidney inflammation. Blood tests, detecting the presence of anti-GBM antibodies in the bloodstream is key to confirming diagnosis anti-GBM good posture syndrome. Tissue biopsy. This surgical procedure removes a small tissue sample from the kidney or lungs, which is examined under a microscope for signs of inflammation or tissue damage. Imaging studies, chest X-ray or CT scan may reveal bleeding or lung changes damage. Thank you for your attention. One moment, I will take photo of your presence. Students, colleagues, who is leader of your group, of group 1, 2, 3, 4, 5, send me a screenshot, not screenshot, but list of present students from your group, okay? Okay.
Ma'am.
Okay, ma'am. Okay, ma'am.
I will wait for your result of present students. Don't forget to send me, okay? Thank you very much. Have a nice weekend and goodbye.
Same to you, ma'am. До побачення.
До побачення.